Happy Thursday, everybody. Welcome to VMR. Prof Rez told tells me that for some reason Thursday VMR is disproportionately displayed on his YouTube, sandwiched between two golf videos, but he only listens to the first 30 seconds and he gets tired of my voice. So this is for you, Prof Rez. Maybe maybe you can make it back past the 30-second mark since I mentioned your name. But for everybody else who's joining, goodbye, Prof Rez. Um, well, very, very excited for yet another iteration of this. And today is a very, very meaningful. I don't know how many times I've introed Maddie. It's many, many, many times. In fact, now we get to co-discuss in non-VMR settings, having done a grand rounds together, which was so, so cool. But my intro for Maddie will be very short and sweet. I think if we stay on the current path and life is as unpredictable as anything, I would surmise to guess that Maddie will be introducing me in the future is the shortest intro to Maddie that I will share with you. Very, very excited to share the stage with you, and I'll hand the mic to you to say hello.
Oh, well, hello everyone, and hello Prof Rez if you're still here. Yeah, I'm just, CB solvers and VMR has totally basically defined my path in medicine, and I am just so, so grateful for the whole community, everyone who I've met here, Robbie especially, and this is just the best hour of the day to get to nerd out with everyone and learn and grow together. So happy to be here. And Robbie, I hope we just keep introducing each other.
There you go. There you go. I love it. We have another person to introduce a guest case presenter, but before we do that, I'd love to thank our Thursday crew. It's just so cool to see people getting into a rhythm and keeping the space afloat. So, as all of you who listen to Thursday will be accustomed to, it is yet again Magnus and Eugene. Magnus is on scribing and Eugene is on teaching points today. So I'll hand the mic to you guys respectively, and then we'll introduce our case presenter.
Yeah, hello everyone. My name is Magnus. I'm from Denmark, and this is truly the best hour of the day. Super excited as always.
Yeah, hello everyone. I am Eugene from Ghana, and I'm so excited to be here doing a teaching points.
Yeah, I think Eugene, you'll have your work cut out because we have a guest case presenter who I imagine is a very fun case for us based on at least the last case that you presented, Fahad. Um, I'll hand the mic to you. Maybe you can just tell us a little bit about yourself because I think the Sunday sessions aren't recorded, and so people may not know you outside the small number of people who were there that day.
Hello everyone. So I'm Fahad. I'm a final year medical student from India. So I can't explain how excited I am to be here and seeing the excitement that you all possess. It's even increasing my excitement. So I got an amazing case here today, but I'm doing good.
God, we're so so excited to have you. I think maybe it's me. I think your video is a little glitchy. So just as a heads up, if the internet is unkind to us, we might have to ask you to turn your video on off temporarily. But so far so good. Fahad, tell us, what do you like to do outside of medicine?
Yeah, outside of medicine, I'm a huge European football fan.
Ooh,
My favorite club is Bayern Munich.
nice.
And outside of medicine and medical school, what I do is I watch football, I play football, and so on.
We a lot. We're not our love for clinical reasoning isn't just our common uniter. I am just like you. I actually, it's crazy. For the last 10 minutes right before this VMR, I was watching the Bayern Munich and Cologne game highlights. And congrats to you and your team for winning 14 games in a row, a record that's never been done before. Hopefully now that I'm being kind to you about your love for football slash soccer, you'll be kind to kind to us with the case. So I'll hand the mic to you to take it away whenever you're ready.
Yes. So we'll begin. So the Aliquot one is just a one primary complaint. So this is a case of a 68-year-old female who presented with the primary complaint of lower abdominal pain since the past 2 days. And I will stop here.
All right, Fahed. Well, first of all, so nice to meet you. And I think I had missed your Sunday VMR. So this is my first time meeting you, and just so nice to meet you. And congratulations on being in your final year of medical school. Um, Okay, so I also love your style of presenting because I love when people stop after the chief complaint because it allows us to really dig into that. So we have, middle to older age woman with lower abdominal pain for 2 weeks. When someone has a chief concern for abdominal pain, I think being cautious about the localization is really important. So as we know, for example, if we were thinking about upper abdominal pain, we always want to rule out, cardiac causes because people can present with ACS by presenting with like epigastric pain. So that's just an example of how abdominal pain can absolutely be an issue in the abdomen, but can also be an issue outside of the abdomen. And so, for example, when someone has lower abdominal pain in a woman, especially, we want to be mindful of, could this involve the GYN system? So I think for me, I'm aware that the patient is using the words, abdominal pain, but I want to be cautious. Is this truly in the lower abdomen, or do we need to be worried about gynecologic processes, ovarian processes, for example? Also, you can have sometimes, back pain that can radiate to the lower abdomen. So I think the summary there is we want to be cautious about localization for abdominal pain. 2 weeks in terms of the time course is interesting here because I'm always curious, how has the disease process been for these 2 weeks? If we were to make a graph of her symptoms, has it been a flat line this whole time? Or have there been certain triggers that have caused flares of these abdominal pain? What is the reason that she presented to care after 2 weeks? So localization, kind of what the quality of the pain has been like for the past 2 weeks. And then ultimately, I always kind of run through kind of highly morbid causes of abdominal pain that I want to entertain in my mind. And we've gone through this quite a few times on VMR, but that includes vascular issues like mesenteric ischemia, I for inflammatory conditions. So for example, in the lower abdomen, could this be diverticulitis? P for perforation and O for obstruction, and some of those can mimic each other. So ultimately, I think my history will be focused on the quality of the abdominal pain, how it's been for the past 2 weeks, and then really understanding is it localized just to the lower abdomen or are there signals elsewhere in the body? Rabih, what's going through your mind with just this short piece of information?
Yeah, I have nothing to add to your localization and where you're understanding things. And I think we've talked about this in the academy before, to remember that pain is really just a fire alarm going off and a warning about an impending catastrophe or fire. And that's the whole point of pain. And unfortunately, when people have pain that is only of hours or days duration, the fire may not be readily apparent. But 2 weeks in, it really should be clear as to why this patient has been in pain. So in parallel to understanding where the pain is coming from is the recognition that the reason the patient is in pain should be more and more and more apparent with every single minute, hour, and day that goes by. And by 2 weeks, the cause should really be very easily detectable if it's going to ever be detected. So if you contrast this to 65-year-old woman presenting with 2 hours of lower abdominal pain, the disease may not have enough time to have boldly declared itself, but by 2 weeks, it should be readily apparent. And so in addition to the abdominal pain, I think you're really looking for, is there anything else going on? And I think that'll be crucial. Yeah, so Mike 2, Fahad.
Amazing discussion, guys. So I'll continue with it. So in total, this is a 68-year-old female who presented with complaints of lower abdominal pain in the past 2 weeks, painful urination since 2 weeks, fever since 2 weeks, and nausea and vomiting since 2 weeks. So coming to history of presenting illness, the 68-year-old female presented with lower abdominal pain for the past 2 weeks. The pain was insidious in onset. It was progressively worsening, radiating to the groin, and it was associated with painful urination. She also developed high-grade fever of 2 weeks duration. It was initially associated with chills and rigor, and it was continuous in nature without any diurnal variation. Additionally, she reported nausea and few episodes of vomiting. The character of vomiting, it was a non-projectile vomiting, the contents being non-bilious, non-blood-stained, and it contained mainly food particles. There was no history of jaundice, abdominal distension, arthralgia, or rashes. And initially, she was evaluated at a nearby hospital where she was diagnosed with a urinary tract infection, and she was treated with antibiotics and analgesics. I'm not sure which antibiotics it is. And on stopping the medication, her symptoms worsened again. She says that her symptoms didn't actually go away, even though she took antibiotics. Now, coming to past history, she is a known case of systemic hypertension since the past 40 years and is on regular medication. She had an episode of an intracranial aneurysmal bleed about 4 years back, which was treated with coiling. There is no history of diabetes, tuberculosis, or any other chronic illness. Family history was positive only for diabetes and hypertension. Her personal history revealed a mixed diet, normal sleep and appetite, and there is no history of any dependence. And I'm going to just give you the vitals and stop this electrode. So her initial vitals were pulse rate of 78 beats per minute, which is regular rhythm, normal volume, blood pressure of 110 over 70 millimeters of mercury, respiratory rate of 14, and temperature of 101 degree Fahrenheit. So I'm going to stop.
All right, Fahid. So the audio is breaking up a little bit, but I think I'm just going to kind of summarize what I heard to make sure it's accurate here. So what we learned is that either preceding or kind of coinciding with this lower abdominal pain was also dysuria and a high-grade fever with nausea that prompted her to go to an outside facility where she got antibiotics, was diagnosed with a UTI. And it sounds like the symptoms did not improve. So now she's presenting again, and she's found again on vitals to be febrile. So that's the story that I'm hearing. So I think now I think it'll be helpful to talk through, how we make the diagnosis of a urinary tract infection and what some of the complications can be for that. So to make a diagnosis of a urinary tract infection, and let me just pause and say that urinary tract infection is a very broad, it's almost like, I almost think of it like as an umbrella term. That means there is an infection in the urinary tract. But a urinary tract infection can be localized to the bladder or can ascend and cause kind of infections in the ureter, in the kidneys, and for example, lead to pyelonephritis. But even just making a diagnosis of a urinary tract infection, you need symptoms. And in this case, we see that she had dysuria or burning with urination. You also need evidence of pyuria on a urinalysis. And that can prompt you to kind of empirically treat, but ultimately you need to have a positive urine culture to ultimately make that diagnosis of a urinary tract infection. And those criteria are important because lots of people, in my residency, you see lots of people with basically asymptomatic pyuria or get a UA for some reason and a urine culture, and there's a bug that grows, but they're not having symptoms. They have a Foley catheter, and it's like, is this just colonized? So that's why it's kind of important to kind of go through those aspects of diagnosing a urinary tract infection. I think already from the data that Fahid gave us, I'm concerned that if this is a urinary tract infection, it is not limited to the bladder because she was having fevers, nausea, and vomiting, and then signs of being systemically ill. So I'm worried that already from the beginning, if this is a urinary source of infection, it has ascended, and I'm concerned it has caused some pyelonephritis. I think the fact that she got antibiotics, I would be very curious which antibiotics she got, because then we can move into the space of, was this an antibiotic failure? And briefly, does that mean that she got antibiotics, but it was not treating the bug that she had? Did she not take antibiotics for a sufficient duration of time? Was this a source control issue and she has a perinephric abscess and so needs drainage or some intervention, and like no amount of antibiotics would fix that. So I think knowing the antibiotics would be really helpful, but I know that sometimes that's not always possible to know. Yeah, and then ultimately, I'm very worried about this person. She's still febrile. She has persistent symptoms despite the timing of 2 weeks and taking these antibiotics. So I think right now, in my mind, this is like a urinary tract infection that has ascended and caused what I'm concerned to be like pyelo or sepsis from a urinary source, and until proven otherwise. That's where I'm framing this right now. Robbie, are you framing this differently? What do you think?
I'm right there with you, and I'd love to do a little bit of a thought exercise with you. More reflex than anything else to sort of illustrate how powerful these things might be. So reflexively, Maddie, if I were just to tweak one detail of this case and say that the pain isn't in the lower abdomen, it's in the left flank,
Hmm.
would this case coalesce with more simplicity for you, or would it become harder? What do you think would happen with that tweak?
Yeah, I think if the pain was in the left flank, then I think it would probably coalesce a little bit easier. Because as I kind of outlined, my concern is that this is
Right.
possibly pyelo, and that's what you would expect there. So you're right. I think the lower abdominal pain is a little bit is an
Yeah.
atypical aspect if we're saying
Right.
this is pyelo.
Yeah, I think that's like such a crucial element, and your chain of reasoning is so pristine. And then it meets some friction with the location of the patient's discomfort, because embedded in your teaching is that when people have a systemic response to a urinary tract infection, it helps you a lot tremendously with the localization if you don't know any more information, which it really helps you think about pyelonephritis. So the question is, do we minimize the localization value of the lower abdominal pain and contort it to say, hey, this could be, as you said in the first aliquot, referred pain from the retroperitoneum, and that potentially she has bilateral pyelonephritis, and that's the case. But it's also helpful to make a list of counter arguments about other places in the urinary tract that can mount a systemic response. So if you were, Maddie, to put pyelo briefly aside, do you have a sense of what other localizations in the urinary tract might make somebody systemically ill?
I would think just kind of anatomically, right? You have the kidneys, you have the ureters, you have the bladder, urethra. Um, I would say issues in the ureters as well,
Good. Yeah.
could cause
Yeah.
systemic illness.
Yeah.
Yeah.
Yeah, that's absolutely superb. I think that, yeah, the all of Pylo involves to some extent, well, most of pyelo. Some forms of pyelonephritis very rarely are actually hematogenous dissemination to the kidney, which we should think about, especially in somebody who's in a TB endemic area. But that's a rare thing that I'll just put to a side. We may visit it in the future, but most pyelo involves ascension upon the ureter. So the
Hmm.
ureter is involved in some way, shape, or form. But I think you're right to zoom in on the ureter, because there might be something residual in the ureter, like a stone or a mass, that is further increasing the chances of that happening. Um, Something that I see not infrequently, Maddie, in older men is prostatitis. And
Yeah.
I commonly teach the residents when I'm working with them in the ER to always keep the two P's in mind of people with pretty sick urinary tract infections. The first P is pyelo, the second P is prostatitis, especially acute prostatitis.
Mm.
And so, of course, this is not relevant in this patient, but it's a stark reminder that patients with midline pelvic organs, like the prostate and the bladder, can rarely have systemic illness. And I want to emphasize, it's rare. So if you told me this is a 68-year-old man with lower abdominal pain, so on and so forth, I'd be like, wow, this is a case of acute bacterial prostatitis. And maybe the patient has an abscess. But this is not relevant in this case. So what is left when you think about lower abdominal pain and a systemic illness? And I think if you center it around the bladder, you're right that regular old cystitis doesn't usually cause systemic symptoms. Um, but the prostate is a great example of the pathophysiology of what can happen, which is that there is external irritation in and around the bladder. So the prostate is one, but if a patient has a tubo-ovarian abscess or any gynecological process that's infected or inflamed, irritating the bladder, the patient can get midline abdominal pain and external dysuria from
Yeah.
irritation from the outside. So if we're taking a mental model most of the time that somebody has a systemic syndrome in response to a UTI that seems to be located in and around the bladder, the first thought is actually, is it external irritation? And in all comers, it's usually from the prostate, but it can be from other things like the appendix, but also the gynecological tract that you mentioned earlier. There is a rare entity called emphysematous cystitis, which occurs in patients with diabetes and often poorly controlled diabetes, where they get a really bad cystitis with gas-producing organisms. So here, I think the tension is how much of the dysuria do we buy and do we invest in that significantly? If we do, then this becomes a febrile UTI, and the febrile UTI is usually pyelo. But a febrile UTI centered around the bladder is often an external structure irritating the bladder, prostate, gyne, GI, but maybe emphysematous cystitis. So that's the sort of mental model that I'm deploying, which really centers and overemphasizes the dysuria. If the dysuria turns out to be noise rather than signal, then this entire framework breaks down. We have to remain much broader than that.
Yeah.
All right.
I'm also wondering, I think I probably, even just without getting
Yeah.
the exam or even the labs, at least in my mind, and curious what you think, I don't think I see a path without a CT abdomen and pelvis, given that this has been going on for 2 weeks and kind of the severity of her symptoms, also with the fever.
Yeah, I completely agree. I think if I were meeting this person, I think the only thing that would yeah, I can't think of anything that would stop me from getting a CT abdomen pelvis. Agreed. All right, Fahid, back to you.
So I'm going to go into the next report. So on examination, she was conscious, oriented, and cooperative, but she looked a bit ill. Pallor was present, facial puffiness was present, and she had bilateral pitting fetal edema. There was no icterus, no cyanosis, clubbing, or lymphadenopathy. And on GI examination, her abdomen was soft, but suprapubic tenderness was present. There was no renal ankle tenderness. Abdomen was uniformly distended, but there was no shifting dullness. There was no hepatosplenomegaly, and bowel sounds were normally present. The respiratory examination revealed bilateral symmetrical chest movements with normal and comparable breath sounds. There was no adventitious sounds. Her cardiovascular system examination was within normal limits. Her heart sounds were regular and there was no added sounds. Her central nervous system examination was also within normal limits with no focal neurological deficits. Now, coming to the initial labs, initially a complete blood count CBC was done, which revealed a hemoglobin of 7.2. Her total count was 5,900 with neutrophilic predominance of 77%. Her platelet count was 2.64, MCV of 88.5, MCH of 28.4, MCHC of 32. Her ESR was 74 and CRP was elevated at 5. A peripheral smear was done and showed normocytic pneumochromic anemia. Then renal function tests were done, which revealed serum creatinine. Her baseline was 1.2 on previous visits. Now, during her previous hospital visit, which I mentioned earlier, they did a serum creatinine and it was found to be 6.2. And now when the patient presented here, it is 13.3. Her urea was 185. Now coming to electrolytes, sodium is 128, potassium is 5.3, calcium of 8.5, magnesium of 2, and phosphate of 7.38. The urine analysis was done. On urine routine examination, the urine was pale yellow, pH is 5.5, and protein 1 plus, and blood, there is trace blood in the urine. Now on microscopic examination, it revealed a WBC count of 15 to 20 and granular cars were present. Liver function test was also done on routine examination, which revealed a total protein of 7.2, albumin 2.8, globulin 3.4, AST of 41, ALT of 14, and alkaline phosphatase of 77. And I'm going to stop here.
All right, we got a lot of information. Fahad, I just want to really applaud you for how you are presenting so expertly. I can tell you put a lot of thought into how you're you know, aliquoting the information in these different aliquots. All right, so I'm just gonna summarize again the pertinent data that we heard. So on exam, of course, we know the patient is febrile. They have suprapubic tenderness without flank pain, and they have bilateral pitting edema, which was a detail I was not expecting in this patient. And then the pertinent things on labs that stood out to me was a normocytic anemia. And I believe if I heard this correct, the creatinine was like 13, and previously it was 6. And some low albumin, and then a UA that showed protein trace bloods, pyuria. We're not hearing if there was kind of nitrites or leukesterase. So I think, whenever there's lots of data, I think it's helpful to focus on the pieces of information that are so abnormal that you have to explain, because that can help you kind of center your thinking without getting too distracted by some other, accompanying abnormalities that might just be might not be the kind of center of gravity of the problem here. So I would say what we absolutely need to explain is this creatinine of 13. And I see the baseline is 1.3. Sorry, I think I had heard 6 before. So this I am translating to a quite severe acute kidney injury. And we all are familiar likely with the you can break acute kidney injury, of course, into pre, intra, or post. Or I like the way Rabih has taught it, is this an issue with the kidney itself or with kind of the plumbing around it? The plumbing being, is there some obstruction in the ureters, for example, kind of post kidney, or in the vasculature supplying the kidney, as in like, hypovolemia, pre-renal. And my understanding is that when you have such a severe increase in your creatinine, that helps to prioritize a post-renal or obstructive process. That's my understanding. And so right now, that's what I'm most worried about, that there's some type of obstruction. And it probably have to be bilateral. So you need to have bilateral obstructive processes. So for example, are like both ureters being compressed in some way that's causing such a severe creatinine elevation. What this is reminding me of is I had one patient who had not quite this significant of a creatinine increase, but it was also maybe from like 1 to 8 or something like that. And just from actually constipation, that person had compression of the bilateral ureters, and then just with management of his both constipation and I think basically that resolved. So that's the reason why I'm thinking that I'm worried about an obstructive process here. So I think ultimately, regardless, I think the next step is still getting imaging, and we want to make sure that we visualize the ureters closely to see if there's compression or an issue with the ureters on both sides. So I think that's my biggest concern. I think alongside that concern is, why does this patient have a hemoglobin of 7? And practically what I would be doing is, if we have access to this, wanting to understand what her baseline is to get a sense of timing. And because I think it's a very different process if this is acute anemia, subacute. But practically what I would be doing is sending iron studies, reticulocyte count. We already have a smear. And then I've been talking a lot, but I think we also have to address, why does this person have bilateral pitting edema without an obvious when you think of that, you can initially go through is this heart, liver, kidney disease, or is there some type of compression that's proximal, like the IVC being compressed? And I'm wondering, because I'm concerned about like an obstructive process, is there something in the abdomen that's compressing the IVC that's causing this bilateral pitting edema? Because we're not getting too much of other flavors of heart failure or cirrhosis. Nephrotic syndrome, I guess there is protein in the urine, so quantifying that would also be important. I've talked a lot. Rabih, what do you make of all this? And like, do you find yourself focusing on those same details or other details?
Nothing to add as per usual. I'll try to help you make a little progress with the information, the distillation you've already made by asking you to think about how the blood pressure helps you connect the kidney to the edema and connect I just think the normal blood pressure is a
Yeah.
interesting finding here. I'm curious what you make of that.
Yeah, I think for the edema, so as I said, like heart, liver, kidney, or some proximal compression, or, is this just venous stasis dermatitis? Depending, like I think an image would be helpful. But in someone who has bilateral pitting edema from, nephrotic syndrome, I would expect them to have high blood pressure. So that would be, her blood pressure would be inconsistent or kind of counter to that. Yeah, I'm actually surprised by the blood pressure because also if she has essential hypertension and she is in a lot of pain,
right?
And both of those things,
Yeah.
so I wonder if this is just basically kind of like hypotension or relative hypotension, given how sick she is. So I should probably be more concerned about that, given that her baseline blood pressure is higher.
Yeah, I think that either the blood pressure is physiologically higher from the kidneys, which we would expect it to be, and there's a parallel process causing it to be low, or it's actually a clue that there's an unusual thing going on here, one of those two. Because if you are going to connect kidney to edema, hypertension is a necessity, because hyperaldosteronism and the triggering of hyperreninemic hyperaldosteronism is the core pathophysiological mechanism of edema in almost all cases of kidney disease, be it glomerular pathology like nephrosis or nephritis or chronic kidney disease. And the absence of hypertension is an interesting clue here because it divorces the edema from the kidney dysfunction and implicates a parallel cause. So you might ask yourself, like, how can the kidneys be involved in edema without hypertension? And the short answer is a space-occupying process in the retroperitoneum. And that way, you compress both ureters, causing kidney dysfunction, and compress the iliac veins, causing edema. It's true, and unrelated. So I think that whenever I see a creatinine this high, as you've emphasized, it really prioritizes obstruction over anything else. And there's a simple reason why. Whenever there's intrinsic or pre-renal disease that is this severe to cause a creatinine this bad, it never gets to this level because the severity and the consequences are so massive that the patient suffers a much more serious compromise earlier. So if you're pre-renal enough to get a creatinine of 13.3, you're going to be so hypotensive and so sick, you'll never get to 13.3. If you have intrinsic renal disease destroying your kidneys so much that you get to 13.3, you lose your ability to make EPO, you lose your ability to make vitamin D. It's often a systemic disease that's destroying the kidneys in the first place. So what is the silent killer of the kidneys? It's post-renal disease. Because it's often in isolation, it's not systemic, and it disproportionately affects just the GFR without messing with other functions. And so the silent killer causing a creatinine of 13.3 in a patient who's having lower abdominal pain, who also has lower extremity edema, really worried that there's something taking up space in her pelvis. Question is, what is it? And I think the real life question is, do you still give her contrast or not? So I think in this case, the hardest aspect of managing her in real life is deciding, do you give contrast or not? I'm really curious what your take is on that.
Yeah, my sense here is that you always need to weigh kind of like risk benefits. And in this patient, as you said from the beginning, like we need to know we need to get an answer of what's going on in the abdomen and pelvis. And my sense is that getting the CT, like the diagnostic value of a CT with contrast is so high that it would outweigh the possible. I feel like I've heard different people have thoughts on like if the contrast-induced nephropathy, like how much of a concern that is. But I think regardless of what that risk is, I think the diagnostic value of the CT with contrast outweighs that.
Totally. I agree with you 100%. And the only thing we'll have to track in addition to that is the fact that she's deeply hypoammonemic and she has protein. So that's the one signal towards intrinsic renal disease and the possibility that she might have nephrosis. When you have nephrosis with the low blood pressure, you have some serious things going on. But I think with her having this high of a creatinine and the fact that she's in pain, would have that be a secondary analysis rather than the primary one. Really, really interesting case.
Yeah.
Yeah, let's see what Fahad has in store with us just for the sake of time. What do you have next?
Amazing discussion, guys. So I'm gonna, without any delay, I'm gonna go into the next report. So normal EKG was taken, which showed normal sinus rhythm. Chest X-ray showed in the right upper lobe, it showed a mild, ill-defined patchy opacity. There was no cavitations, consolidation, or pleural effusion. Echocardiogram was done, which revealed concentric left ventricular hypertrophy with good LV function. Then further, an ultrasound abdomen and a CT KUB was done, which showed the following findings. Her right kidney had mild hydronephrosis. Her left kidney was small size with increased cortical ectogenicity and poor CMB. The urinary bladder wall was mildly thickened. There was no free fluid in the abdomen, and there was no urinary obstruction. So I'm going to start here.
Wait, should I keep going first, Rabih, or do you want to go first?
No, please, of course, always.
Okay. All right. So basically, we've learned that there's not too much signal in the heart. LVH is expected given her hypertension. And then we have this ultrasound. I don't think we've heard the CT yet, that shows hydro on one side, but then not on the other side. The left kidney is small, and there's mild bladder wall thickening. So ultimately, you know, I think the question when we get this piece of information is this explanatory at all for what we need to explain, which is her creatinine of 13? And I would say this would not be, because especially for obstruction, my understanding is that, you know, you need both sides to be obstructed in order to have such significant kidney dysfunction. For example, like if someone just had like a kidney stone on their right side and had right-sided hydro, but their left side was functioning totally fine, my understanding is that your kidney function is still basically normal, and you should have your creatinine at your baseline. So I would say I'm surprised by this, and I would say that this to me, I don't think explains the creatinine of 13.
Yeah.
So we need to keep looking for other answers. Yeah. And I think, you know, there's mild right-sided hydro, so I think we still need to get a better picture of the ureters. And I think a study with contrast would help to see, is there something that this abdominal ultrasound just did not pick up because it's a limited test.
Superb. Yeah, I'll fly through this just so we can have time at the end. Because I think, yeah, I'll just say reflexively, the right upper lobe opacity in the context of a syndrome like this is really, really interesting because it might be a consequence of the kidney dysfunction, especially if you're entertaining the possibility of nephrotic syndrome. Whenever somebody has pulmonary findings in the context of nephrotic syndrome, you worry that they have immunoglobulin loss and have an infection. Alternatively, you could also get venous thromboembolism. So you might have a renal vein thrombosis that has caused a pulmonary infarction. Of course, the most famous pulmonary renal syndromes are the nephritic syndromes, which don't seem to be at play here based on the low amount of hematuria. Alternatively, this unfortunately might be how genitourinary tuberculosis presents. And you have a right upper lobe opacity in somebody who's presumably in a TB endemic area, you have to worry about TB. And the range of GU manifestations of TB are through the roof. So that neuron that we planted accidentally a long time ago about hematogenous dissemination to the kidney is now sort of taking up a little bit more space in my mind, and we can get to that later. I think those are small things, Maddie. Is like, what does the lung mean? Could it be an infection? Could it be clot? Could it be TB? Could it be cancer? I think that we only have a black and white view of that with an X-ray. I think getting a finer tune assessment of it is going to be key. But your analysis of the abdominal ultrasound is superb. And I think we all know this concept much better in a different place. And I think you know it very well, Maddie, when you know that if somebody who comes in with concern for extrahepatic biliary obstruction, that an ultrasound or a CT or even an MRCP may not be enough to prove that there isn't obstruction there, and that sometimes you need an ERCP with an EUS to fully exonerate an obstructive process. And the same applies for hydronephrosis. The ultrasound is decently sensitive, a CT is pretty good, but there are processes, especially processes that diffusely affect both ureters, causing a high pressure, but also blocking the renal pelvis, limiting its ability to dilate to tell you that it's under high pressure. Those are the worst diseases because they're infiltrative in nature and may evade detection. And the only way you know that somebody truly has post-renal disease is you rule out everything else, and then you beg and plead with IR to put bilateral nephrostomy tubes in these tiny little renal pelvises that are compressed by an external infiltrative process. And lo and behold, they start to make a lot of urine. So it's a very difficult diagnosis to make. And 2 or 3 months ago, I had a patient with IgG4 disease, diffuse fibrosis of the ureters, where there's no room left for the ureters to dilate whatsoever. How do they do that? They're literally constricted by everything. And so we ruled out everything else. IR heroically puts bilateral nephrostomy tubes through tiny little holes, and the patient is decompressed. So the key principle here is you had a high pretest probability of post-renal disease, not through the roof, and this test certainly reduces it because it's not positive. But because you started so high and you reduced it, you didn't reduce it back to nil. You reduced it to a lower number, but since your pretest probability was high, you should still keep pursuing. I'm sure we're going to have a lot left to nerd out because this case is really, really interesting. So I'll hand the mic to you, Fahad, to tell us more.
So initially, complement was checked, C3 and C4 level was done with positive, and this prompted an evaluation with a renal biopsy. Now,
I'm
on
so
doing
sorry,
renal
Fahad.
biopsy, what
Okay.
we got
Fahad, I'm so sorry to interrupt you. I think your audio is cutting out to the point where maybe turning the video off temporarily might be a good idea.
is, am I audible?
Yes, yes. Loud and clear now.
Yeah. So I'm going to repeat the report. So
Yes,
initially,
please.
her complement levels were checked, which and the C3 and C4 were normal. Then an ANA profile was done, which surprisingly came back positive. And this prompted an evaluation with a renal biopsy. And we straightly went into renal biopsy, seeing the condition of the patient, and it revealed granulomatous interstitial nephritis with severe tubular atrophy. And I'm going to stop here.
Thank you so much, Fahad. Really, by the way, I also, Maddie, I know I'll give you like 30 seconds to collect your thoughts. I'm so struck with the expert level presentation of this. And I know, that this place is designed to be very welcoming, but the way you're breaking this down, Fahad, is unbelievable. So much learning to be had.
Yeah.
All right, Maddie, what are you thinking?
Yeah, I think the thought on the top of my mind was actually what you brought up at the last aliquot of could TB be responsible for this? The reason being is like the granulomatous interstitial nephritis on the renal biopsy. I'm trying to think if I was taking care of that patient, I would I don't know if I would have gotten to the renal biopsy that quickly. But I think ultimately it's very helpful in this case. And so I think that's kind of the center of this problem, like granulomatous interstitial nephritis. Um, I think TB, and I imagine this patient is in India just based off of where Fahed lives. And so I think that's probably my leading concern right now. Depending on if this patient was in a different part of the world, I think you can also have like some of the endemic mycoses that can involve the kidney and see this finding of granulomatous interstitial nephritis, but probably TB would be my top concern. I think I'm still wondering if that finding would explain the creatinine increase from 1 to 13, because I don't think we're seeing any post-renal process here. This all seems to be intrinsic.
Yeah.
And this would just be surprising to me if like an intrinsic process like this can cause that severe of kidney injury. But I think ultimately the granulomatous finding here is probably the most helpful.
So, so well said, Maddie. I think there's such a wonderful opportunity to sort of intermix everybody's thoughts. So I know we're well, probably shorter on time than we'd like to be, but this case is too rich not to do some breakout rooms. So I'm right there with you, and I think one interesting reflection that we can have later, whether or not people choose to talk about it, is you have hydro. It's maybe underwhelming, but it's there. So that's post-renal. And you have intrinsic renal disease that's biopsy proven. So a very fascinating subspace of medicine, only for elite level nerds like the people who choose to come here, is what is the overlap of intrinsic and post-renal disease? Like what conditions cause both hydro and interstitial nephritis? That's a fun space to reflect on. Hint, IgG4 disease does it. Do other things do it? And I think that's a fun thing to reflect on, and amongst all the things that you just said. So let's create like a 3 or 4 minute breakout room for people to share their thoughts, and we'll reconvene. All right, welcome back, everybody. I hope you had a good time nerding out. I was chugging some matcha. It was delicious. But Maddie, I imagine you were chugging some learning and thinking. What did you all talk?
Yes. So I was with the incredible Catherine, Anmol, and Latufa, and they all mentioned some really great points, including the fact that this patient has underlying diabetes. We haven't heard the A1C, but I think, of course, diabetes can cause significant kidney damage, can cause proteinuria as well. So I'm wondering if there are, in terms of the kidney damage, if potentially two processes, or maybe there was underlying diabetic kidney disease and had this, what I'm concerned to be an infection on top of that. We were also saying that I think, urinary TB is something that we were all concerned about given the granulomatous interstitial nephritis and the pulmonary finding. And then we didn't talk too much about this, but to your question of like things that can cause intrinsic and post-renal disease. I'm curious what's on your list, but I imagine, granulomatous infections, I would imagine would be on that list. And I'm just thinking probably it's all just like infiltrative processes like IgG4, where you can like infiltrate the ureter or cause fibrosis and compress the ureter, and also get into like the intrinsic aspects of the kidney. So that's what we talked about that. But I think I would want to rule out TB first in this case.
Yeah, 100%. I I will use this as an opportunity to plug the CP Solvers Academy and share with you all that we're going to have behind the scenes sessions to talk about the topic that I proposed, intrinsic and post-renal disease. It's absolutely fascinating, and really, really encourage all of you to check out the Academy website, and it's open to everybody. The only thing that we ask is that you come hang out with us, because if you want to hang out with us more, you probably should hang out with us here. It's a very simple premise. But yeah, Maddie, we'll talk a lot about it internally. It'll be a fun academy session, but I'm right there with you. I'll say that the story of genitourinary tuberculosis is a fascinating one that I actually learned as an intern from the legendary Lawrence Tierney, LT, who was Gurpreet's mentor. He taught me that TB's GU story is very simple. It hematogenously disseminates to the genitourinary tract and accesses the kidney through the glomerulus. And then it tunnels into the tubules, into the ureters, and into the bladder. And so what happens is um, there is a little bit of glomerular disease, but not overt nephritis or nephrosis. There's tubulointerstitial disease. There's characteristic signs in the renal calyx where you get calcification and characteristic radiological findings in the renal pelvis. And then it goes down the ureters and causes a diffuse fibrotic reaction. So it is a pan-urinary disease. And when you have granulomatous interstitial nephritis, the probability of your urinary AFB being positive is decently high. So I think that that probably would be the next step. In addition to, of course, culture of the path material from the renal biopsy. You might even at this point consider empirically treating the patient with the right treatment, given the pretest probability is pretty high. I don't think I don't do this without warning, but I may pause for a moment to see if Mark is able to unmute because Mark taught us in the academy about GUTB a few months ago, and had a CT that I actually saved in my files that he shared with us. So sorry for the lack of heads up, Mark, but if you have a second to unmute, would love your reflections about GUTB. It may not be the diagnosis here at all. We're being presumptive, but it's, I think, probably the most important diagnosis to entertain right now. So I'll give Mark like 10 seconds. If not, we'll hear from Fahad.
How can I add anything to this discussion? I mean, I would do the exact same thing, especially in a maybe resource limited setting. I would 100% treat empirically for TB in this case. I think an important mimicker like worldwide is also like schistosomiasis too. I mean, it definitely does not commonly cause a glomerulonephritis, but it can certainly like infiltrate the kidneys, and I wouldn't be surprised if it could cause some like granulomatous reaction on a biopsy. I would have to look into that, but it can affect the ureters. It obviously affects the bladder. And again, it's just very common worldwide. So I would definitely consider that. But yeah, in the case that I presented to Andrew earlier this year, the urine AFB was smear positive, and you can also send a urine mycobacterium tuberculosis PCR if your resources allow too. So usually most of those patients are positive for both of those. So yeah, really interesting case.
Thanks, Mark. That was awesome. Knowing Fahad, he'll probably throw in a curveball at the end here, so we're ready and prepared for that. But I think this is a great opportunity to talk about GUTB. So, Mike, to you, Fahad.
Explain how good this patient is today. So, due to time constraints, I'm gonna rush through the last reports. So, she was admitted initially in the intensive care unit because of worsening renal function. A nephrology opinion was sought, and she was initiated on hemodialysis. Further, urology opinion was also sought, and a DJ stain was done. Then, the twist of this case came when we retook the history from the patient. When the patient informed us that she had history of chronic on and off productive cough for the past many years. So yes, we did suspect genitourinary TB, and hence 3 samples of urine AFB and urine TrueNat was sent. 2 samples of AFB and urine TrueNat came back as positive, and the diagnosis was confirmed as genitourinary tuberculosis. So I'm going to stop here to give you guys a moment to reflect, and then we'll go on to the treatment, how the patient was treated.
I'm just I'm a little bit speechless by your presentation. This was so brilliantly presented, and I think allowed us to kind of dig into so many different teaching points. And so I just really appreciate how much thought you put into this case. And yeah, I think the genitourinary TB makes a lot of sense here. I'm glad that this patient was able to get that diagnosis, and I'm really curious how the patient did.
I share your sentiments, Maddie. This was I didn't think that your Sunday presentation could be outdone, but frankly, I think you have outdone it, which makes me very anxious for your next case. But Mike, to you for your reflections.
Yes. So as the diagnosis was confirmed, she was started on standard anti-tubercular therapy, isoniazid 300 milligrams, rifampicin 600 milligrams, enethambutol 900 milligrams, with pyrazinamide 750 milligram every third day. She was also started on steroids for interstitial nephritis. So the final diagnosis was disseminated tuberculosis, both pulmonary and genitourinary, granulomatous interstitial nephritis on hemodialysis. Patient had right hydroureteronephros, status post-digest ending, and urinary tract infection based on her urine analysis. So that is the case.
This will go down, as Andrew just said, one for the books. This was an absolutely incredible hour. Thank you so much, Fahad. Thank you so much, Maddie, for as always, such a cool, calm, collected, logical, precise, step-by-step analysis of the data to a clear-cut answer. That was awesome. Magnus, a big shout out today. I think the intermittent audio difficulties made your job that much harder, but you were flawless as per usual. And now I get to learn from Eugene. Mike, to you, my friend.
Yeah, thank you so much, Dr. Rabih. And thank you so much, Fayed, for this brilliant, well-presented case. So we started off with an elderly female who had low abdominal pain, and then also subsequently had some genitourinary symptoms, specifically the lower urinary tract. But with the lower abdominal pain, it sparked conversation about what could be the possible etiology. Could it be from a direct abdominal cause, or could it be some radiating pain to the lower abdomen, or even a pelvic etiology? And then we picked up our OG mnemonic, the VIPO. If you're trying to rule out emergencies for an abdominal pain, you could think of vascular causes, inflammatory, infectious, perforation, or obstruction. Rabih taught us that the duration here, if you're actually looking at direct abdominal pains for a chronic event for 2 weeks, should be obvious by that time. But usually insidious or from other areas may not be obvious even at the level of 2 weeks. So we now focused on the lower urinary tract symptoms. Maddy took us through how to diagnose a UTI, that you don't just base on pyuria only, but you also want to look at possible symptoms, which is the dysuria frequency, which was present in this patient. And then you could also top it up with a positive urinary culture. Then you can make your diagnosis of UTI. So this patient had received antibiotics, had risk factors for diabetes, hypertension, and we saw pitting edema in the examination findings. So it sparked conversations to start. Also on labs, on laboratory investigation, we saw elevated creatinine. So it sparked conversation to think about what could be the possible cause of this markedly raised creatinine from the baseline. So putting these symptoms together plus the labs, we could think about 2 possible causes. Rabih taught us that that level of elevation usually is obstructive. Mentioning some important things, which I'll touch on a few, that if there was pre-renal, because you should be seeing over dehydration. If it was intrinsic, you should be seeing other things like possibly raised blood pressure, which was not in this case. And then also in the UA, you should be seeing some important signs like the blood in urine and then protein in urine. And then he circled back to say that it's still possible you can have intrinsic because of the hypoalbuminemia and then the proteinuria in this particular patient. So we're having overlapping overlapping intrinsic and then post-renal cause of the acute kidney injury. So we went on to think about what could possibly cause this overlapping symptoms and causes. And we also had a clue, which was the patchy opacifications in the lungs. This patchy opacifications sparked various discussions in the context of this patient, if it was nephrotic syndrome, which was not the case, but Rabih told us that if that was the case, there could be just loss of immunoglobulins, which is one of the hallmarks of nephrotic syndrome. And so patient will be susceptible to infections or a hypercoagulable state and prone to embolism. However, we're more concerned that this is more of a nephritic. So we're looking at biopsy to guide us. Other things that are usually done is the complements, which was low. And so the final thoughts was a possible an infiltrative process that is possibly invading the cortex medulla, also that could spread into the renal pelvis, calyxes, that is possibly causing this patient's symptoms. And then so looking back with the granulomatous interstitial nephritis on biopsy and then the AFB, we diagnosed GUTB. So looking back, actually, GUTB will present with symptoms similar to chronic lower urinary tract symptoms like chronic UTI. So that was exactly in this presentation. And then it's invasive. Rabih taught us that it's the bacilla usually sits in the cortex. And then when the patient is immunocompromised, in this patient, risk factors being age, the DM, they can now spread into the medulla, and then now they cause this nephritic picture. Then they spread also into the calyxes and then the pelvis, and then cause strictures, obstruction that can lead to the hydronephrosis that we saw in this particular patient. So a very, very amazing case that sparked discussion in etiologies of abdominal pain, sparked discussion in renal diseases, pre-renal, post-renal, and then intrinsic, and then also sparked discussion in glomerulonephritis, nephrotic syndrome, and then finally tuberculosis. So thank you so much, Fayed, again. Thank you so much, Maddy. Thank you so much, Radhi. And then the rest of the chats that was on fire. Thank you.
You know, Eugene, I don't know if you know this, but when you first started doing teaching points, I could tell that you were rushing a little bit because there's a lot of pressure, there's spotlight, and just how calm you are and how comfortable you are taking your time is a marker of your growth and your comfort level. It was really, really cool. Thank you for that. Maddie, since you're going to be introducing me in the future, I think it's fitting that I hand the final word to you.
Yeah, just thank you to you, Rabih, for going through this discussion with me, and Magnus, Eugene, and Fahed especially. Just really enjoyed this hour. I'm excited to read about urinary TB, and yeah, it was a great journey. Thank you all. Come present more cases.